In this segment, I'm going to talk to you about implementing pharmacogenomics in the clinic setting, what's required for it, what the barriers are, and what some solutions are. So the overview of the talk is talking about barriers and solutions, what steps are needed to go to implementation from bench to bedside, genotype dosing guidelines that are available, and some examples of clinical care settings where they are implementing these types of guidelines. So this is just an illustration to show that the cost of sequencing is decreasing a lot. And as the cost decreases, at the same time, the number of variants that are being found, including rare variants, is increasing, and our annotation efforts can't quite keep up with that. So it's causing this, what's called here is an interpretive gap. It's a gap in our understanding of what the variation means and our ability to interpret it for clinical uses. So we're getting to the point where the genome is more affordable. The cost of sequencing a genome is about $1,000 right now, and genotyping across a genome is even cheaper. So we realize that analysis is still going to be the most expensive part, the annotation and the interpretation, because the cost of the actual sequencing is going down so much. And this is getting to a point where the cost of the sequencing is getting to a point where it's more affordable to more people across the US. The other implication is that even with the challenges of interpretation, more and more people are going to get their genome sequenced or genotyped, and they're going to want to use it. So the decrease in cost is actually serving to force the issue on clinicians more and more. Patients are coming with this information in hand that they may have gotten through some kind of direct-to-consumer company where they have their own genotyping, or maybe they're requesting genetic tests more often. And so the decrease in cost is causing both a rush to try to catch up with understanding what these variants mean, but also more and more people wanting that information. So it's going to happen that we're going to have to implement some of this information eventually, because if for no other reason, there'll be patient demand. So what are some of the barriers right now? Why isn't pharmacogenomics being implemented in more places? So here's a non-exhaustive list of some of the barriers to implementation. Clinicians are not always aware of the current advancements in the field. They may not know the implications of some of the research that's out there or the data. Even if they do know that there's this field called pharmacogenomics and that there's some valuable information there, oftentimes they're not sure how or where to even begin, how or where to order a test. There are also some worries about the time delay in obtaining test results. If a patient comes in who's had a cardiac event and the doctor wants to prescribe warfarin, they don't have time to wait a few days or sometimes even 12 hours for a test result to come back. They need to prescribe the drug right then. So that's another concern for physicians in implementing, is that they don't want to have to wait for that time delay, even if they do know how to order the test, which a lot of times they don't. If the test result comes back and says this person has this particular genotype or has this particular variant, that's not very clear about what it actually means to the doctor. So the interpretation part is very important. You have to have a test result that includes that interpretation. Even if you know that the genotype means your person is, say, a poor metabolizer for a particular drug, it's not clear to a doctor what his next step is. They're a poor metabolizer, so what exactly do you do with that information? How should he change what he's doing? So lack of clear guidelines. is another barrier. Some other concerns from healthcare providers are who's going to pay for these kinds of tests? Is it covered by insurances? And there are also ethical considerations in testing people and having their genotypes in their record, in their clinical record. How are people going to react to this, having this information, and is it ethical to give them this information at all times? So some of the solutions to these particular barriers are the following. So for clinicians that aren't sure about the status of the field or how to use pharmacogenomics at all, there's a big push to integrate genomic education into medical training. And we see that more and more medical schools today offering courses, either entire courses or lectures within a course regarding genomics, genomic medicine, and pharmacogenomics. In order to address the concern about a delay in test results, there exists in some settings what's called preemptive genotyping. And that means in some hospital settings, patients, when they come in, not under an emergency situation, but just when they come in as a patient, they are genotyped at that time across their genome. The results are stored in their electronic medical records, and then they're accessible at any given time. So then if a patient does come in with a cardiac event, doctor doesn't have to order a test or wait for a test. They pull up the patient's record, and right there they can see if the patient is a poor metabolizer for CYP2C9 and might have to have his or her warfarin initial starting dose decreased, say. When it comes to how or where to order a genetic test, there are resources out there, such as the Genetic Testing Registry, which I'll mention in a minute. So there are resources for helping clinicians find that kind of information. When it comes to clear interpretation of the results and how to act on them for physicians, what we need is clear clinical dosing guidelines and drug labels that have steps that physicians can follow. And those are becoming more and more prevalent. Also having a clinical decision support system in the electronic medical record so that when a doctor pulls up a patient's record, they can see right then what the patient's genotype is, and if they're in a particular situation where they're going to give a drug that might be affected by the patient's genotype, having a clinical decision support system that pops up a message, alerts the doctor to the situation, goes a long way to helping overcome the fact that clinicians themselves may not know how to handle or how to use that particular information. We need a clear path for reimbursement, obviously, and studies on the impact of genetic testing to help address the ethical and legal issues. And there have been quite a few studies about how people handle the return of that type of information, and they have been overall positive, especially when it comes to pharmacogenomics. Pharmacogenomics is not something that a lot of people stress about compared to some of the disease diagnostics. So it's not been found that having pharmacogenomic information in patient's medical record causes the patient some kind of duress or mental stress. In this segment, I'm going to talk about the things highlighted here. I'm going to mention the GTR, and I'm going to basically focus on the interpretation and clinical guidelines stage and some CDS support.